Thank you very much. First, I'd just like to take this opportunity to thank Robert Reed and Maureen for putting together an excellent program. It's a thankless job, and I just want to be the first to say thank you, and thank you on behalf of everybody in the audience that we could get us all together here to talk about neuroendocrine tumors. I'm going to talk a little bit about the multidisciplinary approach to neuroendocrine tumors and the role that surgery plays in the palliation of these tumors. And I come from this city, and that's Calgary. And in 1998, we developed a multidisciplinary clinic. It consisted initially of myself as an endocrine surgeon, an endocrinologist, and a medical oncologist. And we decided that we would look at and see all of the neuroendocrine tumors. In 2003, we lost our medical oncologist, but we gained a nuclear medicine radiologist and a hepatobiliary surgeon. And throughout this 10-year period, we have standardized our investigations, and we've developed a treatment algorithm that we've tried to put all of our patients through. Although neuroendocrine tumor patients do not fall into a nice category, you fail to read the textbook, and things sort of change as we adapt. But this is what our goal and our intent is. And in that 10-year period, we've now seen over 400 patients with neuroendocrine tumors. The majority of them are GI in origin, with the majority being mid gut carcinoids. And through this experience, because we see all of these patients, we've learned a tremendous amount about neuroendocrine tumors, the way they behave, and the way they behave to our treatment modalities as we move through this 10-year course. So my objectives today were to illustrate the benefit of a multidisciplinary clinic, because I think that is the key to treatment. Although, as a surgeon, I'll tell you the number one key is the surgeon, and the rest of you can sort of follow, but maybe not. I also want to demonstrate the role that surgery plays in the treatment and the palliation, because it's been alluded to, and some people have stated it, surgery is got to be the first thing that we should be thinking of, and you'll see our algorithm is surgically bent. So the format, I'm going to take you through a couple of typical case presentations of what we see very typically on a Tuesday afternoon at the Tom Baker. We'll go through some of the data for aggressive surgical intervention in neuroendocrine tumors, and I will then weave into that our own data from the Tom Baker Cancer Center, and these are my co-investigators. All right, so let's look at a very typical patient, a 66-year-old woman. Typical in the fact that she's had over a 3-year history of these attacks, this crampy, bloating abdominal pain that doubles her over. She would have a history of 3 to 4 days of diarrhea, and then she'd be constipated. Sometimes worse with eating, sometimes not. Sharp, radiating pain, sometimes associated with nausea and vomiting. And every time she went and complained about these, she would be investigated, and ultimately all of the investigations were normal. And they included multiple 3 views of the abdomen, upper and lower endoscopy, upper GI series. Her past medical history, significant in that she had night sweats ever since she had a hysterectomy. But these were getting worse, particularly after any time of stress. So her family doctor placed her on hormonal therapy, saying she was going through her second menopause. She also had a remote history of rheumatic heart fever, and rheumatic fever with a heart murmur that she's had since childhood. So she was diagnosed for over this 3-year period of having irritable bowel, depression, and menopause, until she could no longer eat. And so she lost over 15 kilograms and eventually came into an emergency department. And in Canada, when you come into an emergency department with abdominal pain, you get a CT scan. And this is her CT scan, which is a classic CT scan for a mid-gut carcinoid with this desmoplastic reaction in the mesenteric mass and the spoken wheel. And so at this time, the penny dropped, and the physicians then said, we think we know what's going on here. On the CT scan, her liver was normal, but they realized that a neuroendocrine tumor, now high on the differential, did the appropriate biochemical markers and found that her urinary 5-HIA was elevated, her chromogranin A is elevated, she had a normal MIBG scan, and a faint uptake on her octreotide scan. She went to the operating room and had a laparoscopy, and at the time they found diffuse peritoneal seeding, confirmed they were neuroendocrine tumors. Her liver was assessed as normal, and she had this fixed mesenteric mass. So she was given the diagnosis of a non-functioning neuroendocrine tumor, peritoneal seeding. This was unresectable, and she was told that this was an indolent disease, and we should just be following this. She continued to be told she had her second menopause, and her heart murmur was secondary to rheumatic fever. Well, Mark Ravitch, professor of surgery at Johns Hopkins, said, place your bets on uncommon manifestations of common conditions rather than on common manifestations of uncommon conditions. And in neuroendocrine tumors, we always have to be looking at the rare and the weird and the wonderful. And so when this patient came to our multidisciplinary clinic, we looked at it completely the opposite way. And what we then felt is that she did have carcinoid syndrome. Her symptoms were classical. And we know from our own data that 20% of anatomical imaging will underestimate the extent of liver disease. We felt that she had carcinoid heart disease and confirmed that on an echocardiogram. And the symptoms that she was describing we would attribute to an ischemic complaints of her bowel, and as well as partially having a small bowel obstruction. And we offered her surgical intervention for palliation and to properly stage her. And this is what we find at the time of surgery. And this is the typical bowel sort of being indrawn. This is dilated proximal small bowel, the indrawing of the bowel because of the mesenteric desmoplastic reaction. And when you look closely at the antimesenteric border, you can see this white plaque along the antimesenteric border. That's from chronic ischemia. This is very typical of long-standing carcinoid midgut tumors. We then resected this and have to take out some normal small bowel to be able to get this mass out. The primary is very small. It explains why the upper GI series and the endoscopies are normal. And we had to take this down right down to the root of the superior mesenteric vein and artery. And this is her liver. And if I can teach any of the surgeons in the audience, it's to recognize this miliary pattern of carcinoid tumors. These are flat, they're non-palpable, just little white spots. And each of those white spots is a neuroendocrine tumor. She had a resolution of her abdominal pain. Within the first 3 months, she gained 4 kilograms. We were able to control her flushing with LAR, but not eradicate it. And her diarrhea was now intermittent. And she's been alive now for 3.5 years with obvious disease because that liver was filled with tumor. All right, let's look at another classical patient that we see in our clinic. 53-year-old woman, 8-year history of abdominal pain, intermittent in nature. And over the last 4 years was going through menopause, night sweats, feeling miserable, and then having days where she was well. She presented to one of our emergency departments, abdominal pain, small bowel obstruction, and got the CT scan. This is actually her MRI because it shows it much better, but you can see that she has this large mass, and this is her superior mesenteric artery that completely encases her superior mesenteric artery. And on the coronal views, you can see it and how the artery and vein are traipsing through this. So this, her liver was assessed as normal on anatomical imaging. She had a biopsy of this mass, neuroendocrine, and was labeled as asymptomatic. Again, comes to our clinic, we look at this a little bit differently, and we could show that this woman was having a typical type 2 carcinoid flush, and she had this history of 4 days of diarrhea in a week, and then she would be obstipated or having no bowel movements, and then this cycle would repeat. Biochemistry, she had elevated chromogranin A, urinary 5-HIA, and uptake on her octreotide of this mass in the central part of her abdomen. And it was also took up on her MIBG scan. And because we wanted to offer her MIBG therapy, we decided that we would try to go in, find the primary, as well as debulk as much as we could in order that we could maximize our MIBG therapy. And what we did is we did a 2/3 resection of this mass, carving it off the artery. We found the primary, which was a 1 centimeter tumor in her terminal ileum. And her liver diffusely involved again, these very small microscopic or small sub-centimeter lesions. She remains on LAR therapy. She's undergone 6 courses now of MIBG therapy, and we've decreased her flushing. She has a normal bowel movement every day, and we've normalized her biochemical status. So I believe that the treatment of neuroendocrine tumors is truly multidisciplinary. I could not do what I do without my colleagues, as we have to look at this disease and treat it with various modalities, surgery being one of them, but it is no coincidence that this is a picture in the operating room, because this is where we should be starting when we're looking at these patients. And this is our algorithm that we've developed, and we try to put all of our patients through. They get the biochemical workup, they all get the CT, MRI, octreotide, MIBG, and an echocardiogram. And all of this is done to assess the patient and their anatomical disease for surgical resectability. And if we can completely resect it, that's great. But most of the time, the majority of the time, we are looking at various forms of cytoreductive surgery, and then we will follow the residual disease. And if we can't resect them, or they have residual disease, it depends if they have an endocrinopathy, if we're going to add interferon and octreotide. All right, so let's look at a couple of the features of the mid-gut carcinoids. What about the mesenteric disease? And so you can get a very small primary with this indrawing into a big mass in the mesentery that is really what's probably causing a lot of the problems with ischemia and the bowel obstruction. Well, we know, and the Uppsala group has been instrumental in really showing us the way. Certainly from the surgical point of view, they have been aggressive. And Per Hellman published his series. And of course, it's retrospective, so the patients have not been randomized. There's a selection bias here, but they have a large group for us to learn from. And in 166 patients in where they could resect the mesenteric disease, their median survival was longer, it was 8 years, compared to the 83 patients in which the mesenteric nodes were not resected. And this is just their survival curves, and you can see that this is the resected mesentery with liver metastases had a significant improved survival versus those that did not have their mesenteric disease resected but had liver metastases. And they teased out of their data the group of patients that just had regional disease, i.e. in the mesentery, but no liver metastases. And although it did not quite reach statistical significance, because it was a p-value that equaled 0.05, we do believe it reached clinical significance in showing that there was an improvement in survival if and when you could go after this mesenteric disease. And so they've reported in many other publications that they've improved the quality of life of these patients because they're improving their symptoms, and if you can improve symptoms, you're providing palliation. And they felt that they were delaying the onset of ischemia and small bowel obstruction. Historically, mid-gut carcinoid patients were dying of ischemia and small bowel obstruction, and we learned this morning that that can be as high as 25%. And they were delaying this by going after these lesions. Well, we also have some other, again, it's retrospective data that would support the hypothesis of being aggressive and going after that primary tumor. This group looked at their resection of the primary versus those patients that had liver. All these 84 patients had liver metastases in the neuroendocrine tumors. And 60 of these patients, they were able to go in and resect the primary. And in 24, the primary was not dealt with. And they showed a difference in the median progression-free survival from 56 to 25 months and an improvement in the mean survival. And so they felt that resecting the primary improved their survival, and they postulated it was because there may be some tumor propagating factors that are coming from the primary tumor and feeding through the portal system and into those liver metastases. Retrospective, but incurious as to this marked improved survival. And so at the University of Calgary, we have taken that aggressive approach in our patients, and we are trying to be as aggressive as we can in going after the nodal disease, but also in the cytoreduction of the liver metastases. And all of these patients, as you've seen, are managed in a multimodality therapy. We add radionucleotide therapy, alpha interferon, and somatostatin analogs to all of our patients. And we just recently looked at our Mid Gut Carcinoid patients and just recently published this series. We had 68 GI Mid Gut Carcinoid tumors that underwent a laparotomy. So we had the gold standard of what was found at surgery. 37 of these patients, we resected the neuroendocrine tumor in the mesenteric mass alone. 9 patients were sent to us. They've already had their primary removed, and we went after a cytoreduction therapy of the liver alone. And in 22 patients, we combined our liver cytoreduction with our resection of the small bowel primary and nodal disease. And what we found is we had 59 patients altogether that we can confirm had small bowel neuroendocrine tumor. 24 of these presented with those obstructive complaints that were either partly ischemic or partly mechanical obstruction. We were able to get an R0 resection, so complete resection of the primary and the nodal disease in 76% of our patients, and that included 7 patients that were deemed unresectable at other institutions. We were able to debulk in 8 of our patients, like one of the patients I showed you. Early in the series, I was doing bypasses. We've probably gone completely away from that unless under extreme circumstances. And 3 patients were then ultimately deemed to be non-surgical candidates for having anything done. We were able to get a complete relief of the small bowel and ischemic complaints in the 24 patients that was their primary presenting factor. We had recurrence of obstruction in 2 patients, 18 months and 7 years later. Well, what about the liver, and what about this carcinoid syndrome? Well, we heard a little bit about the effect of cytoreducing hepatic metastases, and I won't go through all of the data because Doug did an excellent job of taking you through that. But if you can cytoreduce the tumor burden in the liver, you can decrease the endocrinopathy. And if you can decrease the endocrinopathy, you are going to be able to improve symptoms, and that is a goal of palliation. And we are seeing, in retrospective studies, as Doug pointed out, some improvement in survival. Well, in our series, we had a total of 31 patients in which we went after the hepatic metastases. And our philosophy is to get a 70% reduction in the tumor volume. If we couldn't get a 70% reduction, we did not proceed with a resection or radiofrequency ablation. In many of these patients, it's a combination of resection with radiofrequency ablation or hepatic artery ligation, and now we're looking at portal vein embolization. We had 58 patients in this series that had florid carcinoid syndrome, and we looked to see an improvement of their symptoms, a subjective improvement, decrease in the frequency of their bowel movements, and a decrease in the frequency of their flushing. And anybody that has come to our clinic knows that you don't go through our clinic without having these questions asked over and over again, and I'm not satisfied until I truly are documented what the symptoms are. And we found that 76% of our patients that had carcinoid syndrome had a subjective improvement in their symptoms. Now, it was a little bit higher in the group that we could reduce their hepatic metastases, as opposed to those where we deemed unresectable or could not change their, decrease their tumor burden by 70% or more, and just went with multimodality therapy. And this figures correlates with our biochemical workup, where we saw if this is urinary 5-HIA with hepatic cytoreduction and multimodality therapy, we had a significant reduction in their urinary 5-HIA. The blue bars are preoperatively, the red bars are 6 months postoperatively. We saw this same reduction with medical therapy alone, and this is overall all the patients in the series. So in total of the 68 patients, we followed them for a mean follow-up of 45 months. We alleviated the ischemia and the small bowel complaints in all of the patients that presented that preoperatively and felt we were getting a 74% subjective improvement in their carcinoid syndrome by putting them through an aggressive surgical algorithm and multimodality therapy. We were able to do this with some morbidity, 22%, but no mortalities. During this period of time, 5 have developed distant metastases, and there's been 14 deaths with a mean time to death of 55 months. And this is our Kaplan-Meier estimated 5-year survival curve, which is 74%, which is in keeping with other centers that have dedicated multidisciplinary clinics and are treating this disease both with surgery, medically, and with radionucleotide therapy. So, just to go on to just a little bit, to address a little bit more into saying that we go with surgery. When patients then progress, we reassess their surgical resection. We have taken people back. We continue to always look at the surgical modalities first in trying to reduce the disease. But even those in which we thought we got a complete resection, we are now learning they are recurring. It's unlikely that we can cure this disease, certainly the ones that we are seeing in the cancer clinics. And so with those patients with progression, this is where we add in our radionucleotide therapy, or those patients that still have residual disease, and we give them MIBG, or at one period of time we were giving them indium octreotide when we had access to that. And again, we published these results and demonstrated that subjectively, with radionucleotide therapy, 75% of our patients were showing some symptomatic improvement with this therapy. But the most important part of this study was that we also had a quality of life index that the patients filled out. And what we found, remember, these patients have progressive disease. They're receiving all sorts of different forms of therapy, including the radionucleotide, that we were able to show an improvement in quality of life in 60% of our patients. 15%, however, found a decrease in their quality of life as their disease progressed. So I hope I've been able to meet my objectives that I outlined at the beginning, and that is to demonstrate the key role that surgery plays in the treatment of neuroendocrine tumors, particularly in the mid-gut carcinoids, in the palliation, and possibly the survival benefit. I also hope I've been able to demonstrate the benefit of a multidisciplinary clinic. Build it, they will come. When we first started out, the Alberta Cancer Board gave us 3 clinics a year. We now have a clinic every week, and we are seeing at least 4 or 5 new neuroendocrine patients a month. I want to thank you for the time to present this work.